Furthermore, you can use Doppler, and one specific Doppler measurement I want to show is the Doppler measurement of the mitral valve, so the measurements of diastolic dysfunction. And here you can nicely delineate the E to A wave, and here we have the systolic part, which is not depicted because the pulse wave Doppler is not across the LVOT, but this E to A ratio is important for diastolic dysfunction. It's important for understanding the timing. Is the sinus rhythm present? It can vary in case of tamponade or pericardial constriction, so you will have a different inflow pattern over the time, so with a larger and a smaller E wave in tamponade and constriction. Moving on to the right ventricle, we want to talk about the TAPSE, the tricuspid annular plane systolic excursion. You measure the TAPSE at the area where the left ventricular free wall is at the tricuspid annular plane. So here you want to perform the measurement. You can do the same with the mitral valve, the mitral annular plane systolic excursion, and with both you can see how left or right ventricular function by means of an M-mode measurement truly looks like. So the value should be above 70 millimeters, and that is how it's done. Here you see the M-mode measurement through the lateral wall, the tricuspid annulus, and here you measure this curve over here. So you start from here and measure to the top of the one bright line you can follow optimally. So here I would follow this bright line all the way through, and this measurement, of course, in this case is above 17 millimeters. With a focused view, it works the same. So you should place the M-mode just at the lateral tricuspid valve annulus. With the mitral valve, you do the same. Here the cutoff is a little bit less compared to the tricuspid valve. For the TAPSE it was 17 millimeters. For the MAPSE it's around 10 to 11 millimeters. So here you see the M-mode and the measurement and the line you would follow. So here you would place the M-mode as seen in this example. Keep in mind, M-mode measurements are sometimes very difficult to interpret by means of, just imagine you have a wall motion abnormality in the specific area over here. You have a large apical aneurysm. Of course, with those measurements, you have the limitation that you only see a very small part and a very limited measurement of what actual left ventricular function or left ventricular contraction or right ventricular function and contraction looks like. For example, in pulmonary embolism, very often the apical segment and also the basal segment, they are contracting better compared to the mid portions of the ventricle. So still, if you have a normal TAPSE or MAPSE, it doesn't rule out left ventricular or right ventricular dysfunction. Another measurement you can perform at the same place where you would place the M-mode. Here you use the TDI measurement, so the tissue Doppler imaging. With TDI you have also these color maps as in color Doppler, and you do see measurements and velocities. The velocities are way lower compared to color Doppler because it shows the values of the myocardium, which is moving, so displacement, and use the pulse wave Doppler to see this curve. So we have here the S primes, E and A prime of the right ventricle, but we want to measure this S prime, and if it's above 9.5 centimeters per second, it's normal. So another measurement you can use additionally to quantify longitudinal right ventricular function. Here are examples of pathological measurements. You see a patient with a dilated, severely dilated right ventricle, dilated left ventricle, dilated atria, severely reduced left ventricular function, also severely reduced right ventricular function. You do see here the measurement of the TAPSE. It looks varying because the patient also has atrial fibrillation, but it's definitely reduced by means of the S prime. It's also reduced in the same patient when you perform this measurement. The tricuspid regurgitation is something you always have to try to find. Very often it's simply difficult and it won't work all the time. So don't be discouraged, but always try to find this small, even flare over here and then place a continuous wave Doppler to quantify the tricuspid regurgitation to calculate the systolic pulmonary arterial pressure. The degree of TR doesn't resemble pulmonary pressures. That is also an important point. In this case, we have the tricuspid regurgitation. We see it's Over here it's physiologic, so it's mild, and with the continuous wave Doppler we get this nice signal where we can actually measure the TR velocity. This is an optimized view, on purpose some foreshortening present. You see here the right ventricle and the left ventricle, they look rather round. It is one intercostal space up, so an foreshortened four-chamber view. In case of TR, it is sometimes easier to foreshorten and move one intercostal space up to optimally visualize tricuspid regurgitation. In this case, we also do see TR. We have seen it before this ventricle, the reduced right ventricular, reduced left ventricular function, the dilated atria, and here moderate to even severe tricuspid regurgitation, I would say. And with the modified Bernoulli equation, we can measure the systolic pulmonary arterial pressure. In this case, the TR Vmax was 3.1 meters per second. And so with the modified Bernoulli equation, you calculate 4 times 3.1 square. So the TR velocity square equals the sPAP. And in this case, it was 38.5 millimeters of mercury with a measurement, which was a mean measurement because of atrial fibrillation. This already concludes the first apical view, the apical four-chamber view.